in our day-to-day practice also, we use ultrasound as a clinical aid also. So I think we'll be wiser and we'll be knowledgeable after this lecture from Professor Binarani Srivastava. Over to you, Dr. Rijuta.
Thank you, sir. Now I would like to invite Dr. Madhu Tumbahampe, Senior Consultant, Chairperson, IRC RCOG, for a welcome speech and introduction of the speaker.
Thank you, Dr. Rijuta, and thank you, Dr. Ganesh, for letting us organize the CME with NESOG. It's a great pleasure to have Dr. Binarani Srivastava, who is a senior gynecologist, also past president of NESOG and a member of IRC RCOG Nepal committee. She did not want a detailed CV, as we all know her. And so just a few words to introduce her. She's worked in various hospitals for the last 36 years in different parts of the country as an obstetrician gynecologist. In government service, she spent about 15 years working in Bir Hospital, Maternity Hospital, and Raj Biraj Hospital. Then she joined Nepal Medical College, where she worked for 15 years as associate professor and professor. And then she moved to Kathmandu Medical College, where she spent another 4 years as professor and retired from there as head of department. So obviously, as Dr. Ganesh mentioned, ultrasound in first trimester of obstetrics is very important for healthy pregnancy and a healthy baby as well. So I would like to welcome all the participants. We have about more joining us as we continue the CME. And thank you, Dr. Rijuta. And I would invite Dr. Bina Srivastava to continue with the CME. Thank you.
Thank you, ma'am.
Thank you, Madhu, for your kind introduction. Respected President NESOG, Dr. Ganesh Dangal, Acting Chairperson, IRC, RCOG, Nepal, Dr. Thumba Hampe, all past president, though they are not here, past president, my seniors, my friends and colleagues. A very good evening to you all. And I would like to actually thank NESOG and IRC Nepal for giving me opportunity to speak on this topic, which I actually very much interested to speak on. And slide, hold on. Yeah. Slides.
Can everybody see?
Can everybody see the slides? Can you see the slides?
Yes, ma'am. We can see the slides.
Okay. Then today I'm going to speak on use of ultrasound in first trimester of pregnancy. You all know that ultrasonogram was first used in pregnancy by Professor Ian Donald in the year 1956 in Glasgow. I have read his book of obstetrics when I was doing my MD. Before he used ultrasound in obstetrics, ultrasound was used by Navy people to detect submarine of enemy in the sea. Currently, it has become a very frequently used basic and essential tool in pregnancy care. It helps us in assuring that baby is developing normally and also help in early diagnosis of complication related to pregnancy. It is essential for all health workers who are involved in pregnancy care to know how ultrasonogram work and what we expect to see in normal and abnormal situation of pregnancy. My objective of presentation is to share knowledge and skill of basic application of ultrasound in first trimester of pregnancy with all obstetricians who are involved in pregnancy care. To achieve this objective, I have actually divided my presentation in two parts. In first part, I will be talking about basic of ultrasound and basic of ultrasound machine. And in second part, I will be discussing about its application in first trimester of pregnancy. Now, in this picture, you can see how sound moves. Sound travels, and you can see that there is it travels in series of vibration, and if these waves are close or tied together, we call it high frequency sound. When they are apart, we call it low frequency sound. Both high frequency and low frequency sound is not audible to our human ear. And sound wave which we use in ultrasonogram are high frequency sound, which is produced by piezoelectric crystal, which is present in transducer, which convert electric energy into sound energy. Then you send this energy, this sound, to the target tissue, which reflect them back to the transducer, where it is again converted into electric energy, and that is again converted into a picture which we see on the monitor. When sound wave hits any object, it is reflected back and it is called echoes. Air and bone reflect most of the waves, and on ultrasound they look white, whereas fluid like urine in the bladder, amniotic fluid, reflect very little or almost none wave and they look black, whereas soft tissue reflect varying degree of waves so that they look gray of varying intensity. Now, echogenicity is a term which we frequently use in ultrasound, and it refers to the brightness or whiteness of image compared to echoes of the surrounding tissue. I have already told you that bone and air, they send strong echo, and they are called hyperechogenic structure, and they look white on the monitor, whereas fluid like liquor, blood, urine send no echoes and called anechoic structure, and they look black on the monitor. Soft tissue send weak echoes, and they are called hypoechoic or isoechoic structure, and they look gray of varying degree on the monitor. Now I'm showing you an ultrasound picture of second trimester pregnancy, and you can see you can see the white structure. This is hyperechogenic, and this is due to reflection from skull bone, and this spine is also white. So bone is looking white, whereas contrast to this is liquor amnii, and it look black because it is anechoic. Now, anechoic, whereas placenta, this is placenta, this is brain matter, this is soft tissue present in chest wall and abdomen, they look gray, and grayness depends upon the consistency of the tissue. Now I will be telling you something about machine. To get a good picture on the monitor, you have to manipulate certain button which are present on the keyboard. First is gain. Gain, by manipulating the gain button, you increase the intensity of echoes, and you get a better picture. Another is time gain compensation, which actually adjusts the gain according to the depth of the field. Now, third one is depth. and it will decide how deeply the sound wave should go in the body. Fourth one is zoom. By actually manipulating this button, you can enlarge the target. And another is focus, which increase the resolution of the target. And last one is freeze. By freezing, freeze button you have to press whenever you want to measure anything. Now, this picture I'm trying to show you the different button. I have just told you this one is gain button, and you increase the strength of the return echo, or you actually increase the strength of the echoes. So but echoes, it should not be very high. If it is very high, then you will everything will be white, and you cannot actually make out anything. If it is too low, the picture will be black, and again you cannot make anything. So you have to adjust it to get a good picture. Now this one is time gain compensation, and you can see this is not one button, there are several buttons, and the upper one you adjust the gain of the near field of the monitor. Middle one adjust the gain of the middle part, and the lower one it adjusts gain of the far end of the picture. So, and you have to adjust gain of throughout the picture to get a better view. Now 3 or 4th is depth and zoom. Is the function of this I have already told you. The last one is the 4th one is zoom. By using zoom, you enlarge the target, and you should keep the target in the center of the monitor to have a better view. The last one is focus, and to increase the resolution, you have to manipulate the focus button. Now this one, I'm trying to show you different type of transducer which is used in obstetrics, and normally we use this one. This is abdominal transducer, and it is also called curvilinear transducer, and it emits sound wave between 3.5 to 5 megahertz. This one is used for vaginal ultrasound. The frequency of the sound wave produced is higher than this. It's emit 5 to 10 megahertz sound wave. And these two we don't use in obstetrics. So more higher frequency you use, you get better picture. But you get better picture, but penetration of sound wave becomes less. Now another thing, another very important thing we have to know about transducer is mark on the transducer. You can see this mark. This is indicator, and this indicator should be on the right side of the mother, and when you are putting transducer transversely, and it should be on the head side when you are putting transducer vertically. And the right side of patient is usually seen on the left side of the monitor, but this is not a hard and fast rule. So to check on which side you will see the image on the monitor, what you can do, put some gel on one side of the or on this side of the where the indicator is pointing on this side. You put some gel and tap it and see on which side of the monitor you see the flickering. Now another thing which one should know who does ultrasound is tomography. Now you can put the transducer in different plane. We all know what is sagittal plane, what is coronal plane, what is transverse plane. So if you put abdominal transducer in sagittal plane, then what actually you do? So when you put it in sagittal plane, you divide the object in right half and left half. So what are the structure? When you divide object in right half and left half and is under the transducer, you should actually, you have to imagine it in your brain. Then you can actually make out what you are seeing. Then another is transverse. You put the transducer transversely, and when you put transducer transversely, you divide the object in upper half and lower half. And if you put the transducer in coronal plane, you divide the object into front half and back half. Now you can imagine that transducer, abdominal transducer, you cannot keep in coronal plane. You can put only in sagittal plane or transverse plane, whereas vaginal ultrasound, you can put it in sagittal plane and coronal plane, but you cannot put it in transverse plane. Now, regarding safety, all the mother, they normally ask you, is it safe to have ultrasound so many times during pregnancy? Yes, it is very safe. Till now, we have not heard or seen any complication due to ultrasound. But if you use it for too long and the power is very high, then ultrasound can rise the temperature of the tissue, and there can be a micro bubble formation, and due to pressure effect also there may be formation of cavity. Now there are two index. The ultrasound machine which is made after 1995, they have two index written on the machine. One is TI, which is called thermal effect index. Another is MI, which is called mechanical effect index. And it is written on the machine. And this tells you about maximum time and power that can be used safely by the machine. When you are doing ultrasound, you have to follow Alara principle. What is this? It is as low, it should be used as low as reasonably achievable. It means that you should not be doing unnecessary ultrasound for a long time, and you should use power only that amount which is needed for your diagnosis. Now I am coming to the second part of my presentation, and I'm going to discuss about indication of ultrasound use in first trimester of pregnancy. The first indication is confirmation of pregnancy. Second is location. By doing ultrasound, you can locate the pregnancy. You can check the viability of embryo. You can do accurate dating of pregnancy. You can diagnose multiple pregnancy. You can diagnose associated tumor in uterus and adnexa. And most important, you can screen for fetal abnormalities. And sometimes you use ultrasound for evaluation of pain and bleeding in early pregnancy. Now, how to confirm pregnancy? Usually, pregnancy is confirmed by pregnancy test, and next thing, you do ultrasound to again confirm it. And the first thing which appear in pregnancy is a gestational sac. What is a gestational sac? It is a fluid-filled structure in the endometrial cavity, and you should see it at 4 weeks in vaginal ultrasound when human chorionic gonadotropin level is more than 1,000 international unit per liter, and by abdominal ultrasound when the level is 5,000 international unit per liter. But this sac-like structure, which is called pseudo sac, can be present in ectopic pregnancy also. Now, how to differentiate pseudo sac from true sac of pregnancy? Now you have to check the position of the gestational sac. The true sac is usually eccentric in location in endometrial cavity, whereas in ectopic, it will be in the center. And wall is very regular whereas in pseudo sac, the wall is irregular. Then you look for double sign in the wall of the decidua. You see two echogenic lines in decidua. You remember when ovum is implanted in the endometrium, the endometrium is divided into three parts. First, where it is attached, it is called the decidua basalis. The endometrium which is covering the embryo is called decidua capsularis, and rest of the endometrium is turned into decidua parietalis. So you have two lines of decidua parietalis and decidua capsularis. So in the wall you will see two echogenic line in two gestational sac. So this can give you an idea whether it is true or pseudo. Now the second thing which appeared is another sac which is called Yolk Sac. And this is a sure sign of intrauterine pregnancy. When you see two sac, one sac and another sac inside that sac, which is Yolk Sac, you know that this pregnancy is intrauterine. It cannot be ectopic pregnancy. The third thing which appear is a fetal pole. Then after 1 week, you can even see cardiac activity in the fetal pole. So these are the four things which you see in pregnancy, in early pregnancy, which confirm a pregnancy. Now this is a table which says when we see these four structures on ultrasound, and you can see that when you do vaginal ultrasound, you put the transducer very near to the target organ and you use high frequency. So whatever actually everything which you see in early pregnancy comes 1 week earlier than abdominal ultrasound. Transvaginal ultrasound is 1 week ahead of abdominal ultrasound. So gestational sac you can see in 4 weeks, Yolk Sac you can see in 5 weeks, embryo you can see in 6 weeks, fetal cardiac activity in you can see in 7 weeks. All these things are seen 1 week late in abdominal ultrasound. Another thing which we should know that when you measure the diameter of the sac, and if it is 20 millimeter, then you should be able to see the Yolk Sac. And if the sac diameter is 25 millimeter, you should be able to see embryo also. And when the length of embryo is 5 millimeter in vaginal and 7 millimeter in abdominal ultrasound, you should be able to find out fetal heart sound also. Now, how to find out location of pregnancy? It is very important, because most of our patients will complain of some pain, and you always think about ectopic pregnancy in that case. And you see do a ultrasound, and if you find a gestational sac with Yolk Sac inside the uterine cavity, you are sure that it is intrauterine pregnancy. Only rarely you can find ectopic pregnancy and intrauterine pregnancy together. Otherwise, you are sure that it is not ectopic pregnancy. Now, this is an ultrasound picture of early pregnancy. Here you can see this is Yolk Sac, this is gestational sac, and this small echogenic thing is fetal pole. Now, the third thing which we would like to check by ultrasound is viability of pregnancy. So for this, you check for fetal heart sound. If fetal heart sound is present, you know that pregnancy is viable and prognosis is good. And I'm telling you again that heartbeat should be present in embryo if it is more than 7 millimeter length. Embryo is more than 7 millimeter. long, more than 7 meters or 7, but if there is no heartbeat, you know that prognosis is not good, and this pregnancy is not going to survive. Similarly, if you see yolk sac and it is 2 centimeters or more in diameter, but there is no embryo, or no embryo, then again, sorry, when sac diameter of the sac is 2 centimeters and you are not able to find yolk sac, or gestational sac is 2.5 centimeters and you are not able to locate embryo, you know that pregnancy is not good. Sometimes what happens, embryo, they don't develop, only sac becomes bigger and bigger, and this is called aneuploidy pregnancy or blighted ovum. And when heartbeat is not present in an embryo more than 7 millimeter length, then you know that this pregnancy is a missed abortion. Now, the fourth important thing is doing accurate dating by ultrasound. Calculation of expected date of delivery by ultrasound in first trimester is the most accurate method of determining it. It is more accurate than doing it in second and third trimester. And to do this, you have to measure the crown rump length of the crown rump length of the embryo when fetal heart beat is present. If it is absent, then it will not give you the correct dating. To measure this, the fetal, you should measure it in fetal mid-sagittal plane when fetal profile is seen and head is in neutral position. Head has to be in neutral position, because if it is flexed, then CR length will be small, and if it is extended, CR length will be more, and you will not calculate it correctly. And dating can also be done by measuring diameter of gestational sac. You measure length, breadth, and height of the sac and divide it by 3 and add 30 days, and you get gestational age in days. But nowadays you don't have to do all these things. The computer will do everything. You just measure the most appropriate diameter of the sac, and you get the gestational age. Another thing we should know, that when embryo is present, then you can do dating by measuring gestational sac and measuring CR length. But you should not, in that case, you should not go for measuring gestational sac, because you have to measure the CR length for that. Now, this is a picture where it is shown how to measure the gestational sac. Now, this is gestational sac, and this is the how you measure. What actually I want to say, that when you are, while you are measuring this, you should measure the black area only. You should not include in the measurement the white area. Only black area should be measured. Now, how to measure crown rump length. Now you can see this baby, it is in mid-sagittal plane. You can see profile of the fetus, and you measure from top of the head to bottom of the buttock. This is the measurement of CR length. While measuring, sometime yolk sac will come in the field, but you should not include yolk sac in the measurement. Now, about diagnosis of multiple pregnancy. Multiple pregnancy can be diagnosed by ultrasound in 4 to 5 weeks. You can see multiple gestational sac by simply counting the chorionic sac. It is possible to establish whether the pregnancy will be monochorionic, dichorionic, or trichorionic, and so on. This type of picture nowadays you can get because we are using more ART than before. But remember, if you see only one sac, it does not rule out later development of monochorionic, di or monoamniotic twins. So that also you have to keep in your mind. Now, zygosity, chorionicity, amniocity are best diagnosed in first trimester of pregnancy between 11 to 14 weeks of gestation. You can diagnose vanishing twin also, and you can do naming of twin also in first trimester. Why we are so much concerned about chorionicity? We are concerned because monochorionic twins are 5 times more at risk of pregnancy complication than dichorionic twins. And in first trimester, 90% detection can be done. It can be done up to second trimester, but detection rate decreases. Now, another thing, we know that dizygotic twin and monozygotic twins, which separate within 72 hours of fertilization, will always have a dichorionic placenta, means 2 placenta. But appearance of the placenta will depend on the site of blastocyst implantation. In case of distant implantation in the uterine cavity, 2 separate placenta can be demonstrated. But in case of close implantation, they will appear fused in a single placental mass, similar to that we get in monozygotic monochorionic twins. Determination of amniocity is difficult until 8 weeks of gestation, because before that time amnion is too close to the embryo and it is identifiable only in 50% of cases. Now, how to determine chorionicity in twin pregnancy? First, you check the number of placental masses. If you are seeing 2 placenta, you are sure that it is dichorionic placenta. If you can check gender of the fetus and it is different, you know that it is dichorionic twin. But most of the time, because in about 30% cases, no, 70% of monochorionic cases, the placenta is actually fused. So in those cases, you have to check the thickness of dividing membrane between the twins, and you look for lambda and T sign. Now, this is an ultrasound picture of multiple pregnancy, and you can see 2 sac, 3 sac. By seeing multiple sac, you know that it is multiple pregnancy. Now, this is also a picture of twin pregnancy, and in this you can see one placenta is on the anterior wall, another placenta is posterior wall. So we are 100% sure that this is dichorionic placenta. Now, difficulty is here. This is one placenta. The 2 placenta has fused and it looks like one placenta. When you get this type of situation, you check the intervening membrane. So if thickness in dichorionic, the dividing membrane is thick because you get 2 chorion and 2 amnion, and 2 chorion and 2 amnion. And if it is less than 2 millimeters, then you know that it is not dichorionic. Another is this lambda sign. The place where this membrane is attached to the placenta, there is widening of the tissue. There is widening of the tissue, and this is called lambda sign. So you have to look for thickness of the dividing membrane, and you have to look for lambda sign. If you find both these factors is present in this picture, so this is dichorionic placenta. This twin is dichorionic. Now another picture. Now again, there is only one placenta in this case, but the dividing membrane, if you compare with the previous one, it is thinner than that, and there is no widening of tissue at the attachment. And this sign is called T sign, and it is present in monochorionic twin pregnancy. Now, this is monochorionic. This picture is of monochorionic monoamniotic twin, and it is very important to diagnose this condition because 1% of monozygotic twin can be monoamniotic monochorionic, and maximum complication you get in this type of twin, so it is very important to know. Now this is a picture of conjoined twin. Sometime you can get this, and if you know, you can terminate this pregnancy earlier by as you do for any abortion. But if you diagnose it later, then maybe you have to do cesarean section. Now this is another picture where you can see the lambda sign. Now we have finished examination of uterus, of the content of the uterus. Now we move to examination of uterine wall to detect any tumor in the uterine wall. So after you have finished with the examination of fetus, you check the wall for presence of any fibroid, because it is typical to it has got typical picture. It is not difficult to diagnose fibroid, and it is very important to diagnose number of fibroid present if possible, and the location of fibroid present, because if it is situated posteriorly or on the fundal area, it will not give that much of trouble. But if it is on the anterior side and near the cervix, it may give trouble during the delivery. And a diagnosis of fibroid is easy in first trimester. It is very difficult in later pregnancy. Now, when you have finished examination of the uterine wall, you check the adnexa for presence of any ovarian cyst. This is also very important. Diagnosis again of small ovarian cyst is easy in first trimester, difficult in late trimester. So you check the adnexa for presence of any cystic structure. The ovarian cyst could be a cystic mass, or sometimes it could be solid or complex also. But normally you find a cystic mass in the ovary if ovarian cyst is present. Now coming to screening and diagnosis. You heard that, na? You mirrors lekhe mein answer. This one. Now comes screening and diagnosis of fetal and maternal problems. By first trimester ultrasound, you can diagnose aneuploidy. Not diagnosing, you can actually say that there is a great probability of having aneuploidy baby. You can screen for congenital heart disease in the baby. You can detect neural tube defect, and you can predict preterm birth, stillbirth, IUGR, diabetes, preeclampsia, which can develop later in pregnancy. In that case, forgetting all these things, you actually check the ultrasound finding, and you add to this some biochemical result and risk factor present in the mother, and you can predict all these conditions. So if we know that this woman may develop these problems later on, you can start treatment very early, and prognosis is good. Next. Next. Now to detect aneuploidy, we measure nuchal translucency. It is actually collection of fluid under the neck. You check for nasal bone. You check for reverse A wave in ductus venosus, and you check for tricuspid regurgitation. It is easy to check nuchal translucency and nasal bone with training, but reverse A-wave inductus spinosus and tricuspid regurgitation is difficult. Only those people who are expert in fetal echo, they can do it. So we will be talking about nuchal translucency and how to check nasal bone in this presentation. Now, nuchal translucency should be measured between 11 to 13 weeks with 6 days of pregnancy, when CR length is between 45 to 84 millimeter. After 14 weeks, you will not be able to measure it because it disappears. For measuring this, fetus should be again in mid-sagittal plane. Image should be magnified so that it filled by fetal head, neck, and upper thorax. The amnion must be seen as a separate from nuchal translucency line. The electronic caliper must be used to perform the measurement, and measurement must be performed at the widest space of the nuchal translucency. Now, you can see in this picture, the picture is filled with head, neck, and upper thorax only, and you are not able to see another part of the fetus. And baby should be in mid-sagittal plane. So how to confirm that baby is in mid-sagittal plane? For that, you look for this echogenic thing. This is due to hard palate. If you can see this hard palate, you know that baby is in mid-sagittal plane. So mid-sagittal plane, and now you measure this thickness. This is nuchal translucency, and you measure this. It should not be more than 3 millimeter. It should be less than 3 millimeter. Now another in the same field, you can see nasal bone. Now see these two echogenic small thing. The lower one, this is called actually double sign. So the lower one is nasal bone, and above this is echogenicity is due to nasal skin. So this is double sign, and there is another echogenic thing also. This is because of the nasal tip. So you measure length of width of this nasal bone. It should be present, and it should be 2 millimeter in diameter. Now this is another picture. I have already explained it, and this is in this picture. You can see how it should be measured. The horizontal arm of the caliper should be on the inner side of the white line. The horizontal arm should be on the inner side of white line when you are measuring it. So this is normal thickness, and in this you can see it is increased, and this is amniotic membrane. So you can see it is separate from the nuchal thickness line. Now the last one is how we evaluate pregnant women coming with pain and bleeding in first trimester. All of us, we encounter women who are pregnant and they come with pain and bleeding in first trimester, and we have to answer them why it is happening. One thing we should remember, that pain and bleeding can occur in normal pregnancy also. So how to know that it is normal pregnancy and why we get pain in normal pregnancy? You know, stretching of the ligament can cause pain in normal pregnancy also, and bleeding can also occur in normal pregnancy because of increased vascularity, and you get some bleeding till decidua capsularis has not joined with decidua parietalis. To diagnose miscarriage, you know, you again check for size of the gestational sac. If it is 2 centimeter, 2 centimeter or more, you should be able to see gestational sac. If it is more than 2.5 centimeter, you should be able to see the embryo. If embryo is more than 7 millimeter, you should be able to locate heartbeat. So if it is more than that, and but you are not finding the desired object, you know the prognosis is bad, and she is going to miscarry this. Now, to diagnose incomplete abortion, usually we find in incomplete abortion, you have to actually check his history. The woman, along with pain and bleeding, will give history of passing some mass also. And when you do ultrasound, you will find thickened endometrium with abnormal tissue and fluid in the uterine cavity, which is suggestive of incomplete abortion. In molar pregnancy, this is picture of incomplete abortion. In molar pregnancy, you will find the whole uterine cavity is filled with cystic thing, and which gives no storm appearance. And if the woman is pregnant, pregnancy test is positive, but you cannot find anything in the uterine cavity, but there is fluid in the pouch of Douglas. It is suggestive of ectopic pregnancy. When pregnancy test is positive and uterus is empty like this, and there is adnexal mass, then you know that it is ectopic pregnancy. Yeah. Now I have come to the end of my presentation, and I would like to summarize whatever I have told you in my presentation. First thing, you should remember that correct holding of transducer is very important for correct orientation of image. Indicator on transducer should be on the right side or towards head end of the mother. Third one, it is important to understand function of gain, time gain, compensation, depth, zoom, focus button, and you should also know how and when to manipulate them. Ultrasound should be done only when it is indicated. Unnecessary ultrasound should be avoided. Gestational sac with the yolk sac is the surest sign of intrauterine pregnancy. CR length measurement of embryo with heartbeat present is the most accurate measurement of gestational age. Yolk sac should be present when gestational sac is 20 millimeter in diameter. Embryo should be visible when gestational sac is 25 millimeter in diameter. Heartbeat should be present when embryo is 5 millimeter long. Nuchal translucency should be measured between 11 to 13 weeks plus 6 days only. When pregnant, week of pregnancy, then CR length is between 45 to 84 millimeter. Nasal bone should be visible and it should be 2 millimeter wide. Positive pregnancy test with empty uterine cavity and fluid in pouch of Douglas or adnexal mass is suggestive of ectopic pregnancy. Thickened and irregular endometrium with fluid and abnormal tissue in the cavity is suggestive of incomplete miscarriage. Uterine cavity filled with cystic tissue is suggestive of molar pregnancy. So with this, I end my presentation. But before I end, I would like to thank Professor Sudha for pushing me to do this presentation, and Dr. Madhu for helping me in making this presentation. Thank you, Madhu.
Thank you, ma'am, for such an elaborate and simplified presentation. We are very happy to be with you in today's CME. Now, I would like to open the floor for discussion. Any questions? We can put it for ma'am.
Okay. Any questions? Dr. Savannah Pradhan has raised her hand.
It's in Malayalam.
Did you tell a question?
Hello. I can see Dr. Savannah is trying to raise one question. Please unmute yourself and ask the question.
Right.
Dr. Savannah?
Yes, yes. I hope you can hear me.
Yes, we
Yes,
can.
we can hear you.
Thank you very much, ma'am, for the presentation. I have a few questions. Ma'am, you said that you this first trimester ultrasound, you can diagnose many things, but I wonder how can you diagnose diabetes, preterm birth, and stillbirth in first trimester?
You cannot diagnose, you can predict. You can
Exactly.
predict.
Exactly. I mean, predict, that's fine. I mean, that is my question. How can you predict diabetes and stillbirth and preterm birth? Like a stillbirth, maybe if the fetal heart sound, if you cannot find, but stillbirth itself, by definition itself, in first trimester, I mean, I could not completely understand about this prediction of stillbirth, diabetes, and preterm birth. That is one question, ma'am. And I have another question about the ovarian cyst. Sometimes like thecal luteal cyst in first trimester could be completely normal. So if you say that there is a ovarian cyst, sometimes you may be doing something, I mean, unnecessary intervention if you do not think that there is a physiological cyst in first trimester. And that is my second comment. And my third one is, ma'am, I mean, when you said that conjoined twin, like you can also suggest for abortion, that's fine. But my comment in that one is like, I mean, there are so many things that intrauterine intervention, which is not done in Nepal yet, but there is a scope for that, for the intrauterine intervention. So this conjoined twin, I mean, if you could diagnose what type of conjoined twin it is, so that, I mean, we may not directly suggest abortion. I mean, we can open the platform for the future treatment. I mean, that is one of the things that came into my mind. Thank you very much, ma'am.
Thank you, Savannah. Your questions are very important. First, I would like to answer your third question. You are very right. It is not, it should not be our decision to terminate the pregnancy, because you know, throughout the world, there are so many conjoined twins. We are doing very good. So if mother wants termination, we can do it because it is legal in our country. If they want to keep that baby, it is fine. Regarding your second question, what it was? Ovarian cyst, right? So ovarian cyst, you know, it is good to diagnose that there is something, some cyst in the ovarian, and physiological cyst, we never actually give any treatment for physiological cyst. But if it is big, it depends upon the size of the cyst, whether you are going to treat or you sometimes you just leave it and you give treatment at the time of delivery if it has not given any trouble to the mother. So diagnosis is okay, and your further treatment depend upon the size of the cyst, and if it is giving any trouble, of course you have to give treatment. Otherwise you can leave also. You don't have to remove it all the time. And the third one is regarding prediction of IUGR, stillbirth, premature labor, preeclampsia, diabetes. Yes, nowadays it is being done in good center. You know, they take the, I don't know every detail of this, but they take some ultrasound finding, and to this they add some biochemical results, and they add a risk factor of mother, and after considering all these things, they predict whether she is going to have all these problems in future or not. It is good, it is, isn't it? When you know that this woman can develop IUGR or preeclampsia in later pregnancy, you can start aspirin. So I hope I have answered your all the three questions.
Thank you, Dr. Savannah, for your question. Thank you, ma'am. Is there any more questions?
Do you want to add?
It's okay.
Madhu would like to add to my answer.
No, it's just we are getting newer risk factors, tumor markers, and other.
It is not only on
unnoted
ultrasound. You add many things. You add the
Age,
biochemical result, you history, age, her own medical history. You add up all those fine, and then you can predict. If you have seen
Risk
some
factors.
prescription from Delhi, you must have seen that they predict and they start treatment.
It's just prediction.
No more question.
Rogina is.
Rojina, timine answer gar.
Yes, Dr. Rosina, please unmute yourself and please put your question.
Good evening, ma'am. Good evening, everyone. Thank you so much, ma'am, for this comprehensive talk. Really delighted. Actually, I want to add a few more points over here. I've just come back. I've finished my fellowship in fetal medicine. So ma'am is very right that we can predict the stillbirth, preeclampsia, and FGR. And we can actually take care of these conditions right. The screening can be done right in the first trimester screening. It's not just about the scan that we do in the first trimester. Along with the aneuploidy screening, we also check for the anatomy of the fetus right in the first trimester, whatever is possible at that point of time. And then we can predict the risks for preeclampsia and FGR and stillbirth and preterm. So in the first trimester, not just the ultrasound markers, we also take the uterine artery Dopplers, and we also take the cervical length measurement, and then it is integrated with the PAPE value. So if along with the PAPE value, if we have PLGF as well, then it is the detection rate is even more. If only as compared to if we take only PAPE. So if we integrate all these factors and then calculate it in the software, then we can get the risks for FGR and stillbirth and preterm, so that we can start with the aspirin. Now it is recommended that aspirin should be started in the dose of 150 mg till 36 weeks if the risk for preeclampsia and FGR is high. So it can take care of in 80% of cases if the prediction gives a positive result. That it is especially true for the preterm FGR, which is evident before 32 weeks period of gestation. So I think we should advocate not only the nuchal scan and Down syndrome screening, but it also helps in the screening for preeclampsia and FGR and stillbirth, along with preterm labor. So if the cervix is less than 25, when we measure it in the first trimester, then we can start with this vaginal progesterone and then call her for follow-up. So if it is even more shortening, then we can go for surgical management like Cerclaz and all. Thank you so much.
Thank you, Dr. Rosina.
Okay, sir.
The floor is still open for discussion. If someone would like to put some question for our Dr. Veena.
No more
Questions?
I think ma'am has answered most of all our questions, so I don't think there are any more questions for Dr. Veena today. It was a very nice and elaborate presentation, ma'am, and we had a lot of queries, but I think most of them got answered.
The future is there for.
Dr. Rijita, are you there?
Yes, sir.
I think now it's time for vote of thanks, right? Dr. M.
If there are no further
Now,
questions,
if there are no more discussion in today's CME, I would like to invite Dr. Yam Prasad Dua, General Secretary NESO, for the vote of thanks.
unmute गर्नुपर्छ। तर हजुर होस्ट हुनुहुन्छ एकचोटि गर्दिन मैले यहाँबाट गर्नै मिलेन।
तिमीले अनम्युट गर्दा हुन्न के भयो?
अघि आक्स त गरेको थिएँ मैले यहाँबाट नभएको कि
कोहोस्ट गराइदिन्छु नि, मेक कोहोस्ट।
कोहोस्ट बनाइदिनु भयो भने त
ओके, ही इज नाउ कोहोस्ट। डॉक्टर एम,
कसरी कोहोस्ट बनाउँछ?
Good evening and namaste to everyone.
Good evening.
So, अघि अलिकति प्रब्लम भयो नेटमा, अनम्युट भइरहेको थिएन। So it's my privilege to propose a vote of thanks, and which I'm doing in every seminar. So first of all, I would like to thank the chairperson of today's presentation and the president of our society, Professor Ganesh Dangal, for his valuable time in these excellent presentations. And I would like to thank chairperson RCOG Madhudumba Ampe ma'am for her presence in this presentation. And the most important person of today's presentation, Professor Dr. Binarani Srivastav. I would like to thank her for her excellent presentation, making the floor most interactive, answering all the questions that the participants had raised. And definitely this program has been run smoothly because of our dynamic host and moderator, Dr. Riju Taza. I would like to thank her. And I would like to thank our office secretary, Ms. Sabina, for our untiring effort to incorporate all these 74, 75 participants to be here in this today's webinar. So I would like to thank her. I would like to thank again the NREN, who is providing us a Zoom platform and uninterrupted platform for this presentation, which is making our scientific session more effective. I also like to thank all the active participants and those participants who has spent their time to listen to this excellent presentation. Finally, I would like to thank you all and have a very good evening. Thank you.
thank you.
Thank you, Dr.
Thank you,
Yam.
everyone. Namaste. Good night.
Good night.
Good night.
Okay.